as we go from measles to malaria. And Joel Breman, who started in Guinea with the smallpox, measles, smallpox in India, and now with the Fogarty Institute, will bring us up to date on some of the challenges of malaria. Joel?
Actually, I've retitled my talk here. I'm going to talk about a disease control priorities project which addresses all diseases, and I'm going to use malaria as an example. But first, I'd just like to comment. Thank you for arranging this seminar, scientific seminar. I'd like to comment that nothing we could do in the field could be done without the support of our partners. Last week, Stan and Dottie Foster celebrated their 50th wedding anniversary up in New Hampshire. So Dottie couldn't be here today, but she represents many partners who gave us moral and physical sustenance. So, there we go. The project I'm going to talk about represents an alliance of organizations that are geared toward developing a set of activities based on creating evidence, divining evidence from previous work done, and disseminating the evidence to improve health in poor countries. The partners are a scientific organization at NIH, where I belong, and I was the managing editor of this project. The World Bank, a development organization, WHO, a global public health organization, and the Bill and Melinda Gates Foundation, a divine healing organization. The goal of this enterprise are utopian, actually. You can see that disability, death, and economic burden are now in the forefront of how we talk in public health. We've developed an evidence base by providing cost-effectiveness analysis, by defining disease burdens as precisely as possible, summarizing past experiences, many of which you've heard about today, and moving forward and saying which are the best and the worst buys in terms of investing your resources, disseminating the results, and most importantly, having countries and areas within countries define their own priorities and act on them. The metric we use has been the disability-associated life years. How many here know and have used disability-adjusted life years instead of morbidity and mortality? How many of the EIS officers use disability-adjusted life? Very few. Well, this is an ingenious metric that not only does case counting of what's out there, deaths and disease, but makes adjustments for a weighted disability, blindness, cystic fibrosis, inability to perform psychologically, and then adapts this to the life expectancy of those individuals and comes up with the burden. By using the disability adjusted life year, perinatal conditions end up number one. Pneumonia and then cardiovascular disease with myocardial infarction and stroke, followed by HIV, diarrhea, depression, malaria, COPD, tuberculosis make up 40% of the global disease burden, and these are followed by auto injuries and suicides right after that. So this is a way of looking at things. True, cancer is a very important issue, but most people get those diseases late in life, important as they are. They don't make up the global disease burden. Now, looking at where the burden is macroepidemiologically, we could see that Sub-Saharan Africa, let me go back here, making up 13% of the world's population in the low and middle income countries, areas I'm going to focus on, comprise 25% of the global disease burden and moving over 54% of the infectious disease burden in the entire world. And within sub-Saharan Africa, infectious disease comprise 59% of, this is the wrong one. Of the burden here. Can you see that pointer in the back or not? Not so well? Okay. 59, you can see that? Rafe, put on your glasses. Okay. Oh, thank you, Rafe. Okay. And South Asia, let me get mine. And here, with 27% of the population, comprises over 30% now of the disease burden, 30% of the infectious disease burden, and within that area, 30% of the infectious disease burden. So I'm going to concentrate on those areas of the world because when you look at the big seven, pneumonia, HIV/AIDS, diarrhea, TB, measles, and the really big one, malaria, or sub-Saharan Africa, you see that in sub-Saharan Africa and South Asia, they're number 1 and 2 in terms of their percent. This is 100%, that of those diseases, these areas of the world comprise the major source of diseases. A quarter of the disease burden in the low and middle income countries are due to these 7 infectious diseases. Now, let's talk about malaria. The manifestations of malaria from the infected mosquito are myriad. Anemia, low blood sugar, respiratory distress syndrome, low volume, cerebral malaria for acute malaria. For the chronic effects of malaria, anemia and multiple neurologic and psychologic syndromes result in impaired growth and development. And for the pregnant woman, the impact on the fetus resulting in low birth weight, abortion, stillbirth, and for the mother, acute illness and anemia comprise these manifestations. What is the burden? Tough to define. Between 1 and 3 million deaths just in African children, and that's why Jean Roy is talking about distribution of insecticide-impregnated bed nets. But severe anemia, low blood sugar, and low birth weight are really the major offenders in terms of the burden, and interventions have to be directed there. So interventions. The new epidemiology links economics to it, and so you tote up the costs of a disease, the effectiveness of the intervention, and you can compare it against the costs and the effectiveness of other interventions to come up with the incremental cost effectiveness of what you're doing. And in our project, we've looked at over 300 personal and population-based interventions, and using malaria as an example, to prevent low birth weight babies, you give pregnant women intermittent preventive treatment. You switch when drug resistance develops, and you could see that the range, this is not any statistical computation, it's a range of the studies that were teased out by a veritable army of economists and epidemiologists looking at data. So here is the cost effectiveness between $3 and $25 per DALY averted to prevent, to avert a disability associated life years with these interventions. Here we have the new drugs, artemisinin combination therapy, household spraying, and here is using sulfadoxine pyrimethamine even when there might be some resistance. If an intervention has a cost-effectiveness ratio of less than $150, it is exceedingly attractive even for the poorest of the poor countries. So we have defined best buys, which are often neglected opportunities. Immunization is by far the very best buy. These are the dallies that could be, this is the burden of disease in sub-Saharan Africa and southern Asia. And just to compare it with traffic injuries that I mentioned, speed bumps and penalties, but particularly speed bumps, are exceedingly cost-effective, something that poor countries can deal with. Now, what are the interventions that ministers of finance and health and presidents of countries might consider as not so cost-effective? Well, if you look at this chart with cost-effectiveness, high here and high here, you see that some interventions should be used widely, some might be scaled back, some are neglected opportunities, and some might not be used so much and be scaled back if they're used at all. We've talked about malaria. We haven't talked about HIV/AIDS, which has many cost-effective interventions for prevention and even for treatment. But if adherence is poor to HIV/AIDS treatment programs, then this can be so costly that you will actually create damage by having a program expending so many resources. Here we have leishmaniasis, a focal disease, but for countries like Sudan and India, where they have massive outbreaks periodically, cost effectiveness is very high, but the avertable burden of disease globally is low. Parkinson's disease, deep brain stimulation might not be recommended for the Minister of Health of Conakry or Sierra Leone as a massive undertaking in terms of training and equipment. So here is for a decision maker what he will do with a very thin envelope in terms of investment. He will avert 50,000, or she, 500,000 dallies by expanding the immunization, by switching to artemisinin combination therapy. There will be this gain. Improving neonatal resuscitation. There are a number of things to do here. Adding the new vaccines. This is exactly what will occur. So let me conclude with some main messages. Better data are needed. Obviously, the burdens I presented represent a lot of passive, imprecise reports. The way I like to express it is with this, the ears of the hippopotamus, representing what we see with malaria. The reports come in from health units, but the real burden of disease is here, and the EIS class is going to be spending a good part of their life defining burden globally by doing surveys and special studies involving defining the entire hippopotamus. So infectious disease agenda, they predominate in sub-Saharan Africa. All countries, including ours, have vulnerable groups. Children under 5 are those most susceptible. Something that's also come out of the Disease Control Priorities Project is that of the close to 15 million deaths now under 5s, a quarter of them occur in the 1 to 5 year group, a quarter in the 28-day to 1 year group, and then a quarter in the 0 to 28-day group, and a quarter are stillbirths. Each of these areas merits special attention, studies, and interventions. There are preventable levels of morbidity and disability that I've described on the charts. The unchecked HIV/AIDS pandemic is the huge challenge. And what I see as a major challenge in the 21st century is a look at the infectious causes of the so-called non-communicable diseases. I'm a believer that all non-communicable diseases are caused by infections. Of course, now we know that heart disease and so many cancers and even brain diseases have infectious origin. So let's do research on that. Be prepared for what we can't quantify, but we're following closely. We've talked about the very good buys, the not so good buys, massive treatment of dormant TB without HIV is like poor compliance for HIV/AIDS programs, very cost ineffective. And then the importance of research. I could have another 10-minute talk on just the research issues related to future investments and the payoff. Training leaders in research and operations, absolutely key. Focus on low and middle income countries where 90% of the global burden resides. And then collaboration, as was talked about, shared goals and mutual benefit. Let me end with my homage to CDC and to the smallpox program. T.S. Eliot says it beautifully, home is where we start from. As we grow older, the world becomes stranger, the pattern more complicated. Certainly CDC and the smallpox program have made the world less strange, slightly less complicated for me, but we're still working, devoting our careers and lives toward the living based on what we know from the dead. Here are the books that were just published in April from the Disease Control Priorities Project. There are 3 books that came out. One is a 73-chapter, 1,400 5-pounder, a 200-page summary in 7 languages, and then all the statistics you'd ever want to know about regions and countries. This book is an update of the 1996 Murray and Lopez tome, and Murray and Lopez are still affiliated with it. This is the 2nd edition of the Disease Control Priorities in Developing Countries that the World Bank published in 1993, a smaller book with a few cost-effective interventions. This book in 1993 was dedicated to the world's smallpox workers who eradicated that disease. Thank you, Stan.